All right, good morning, everybody. I'm Lieutenant Commander Caudell. First, thank you to Colonel and Mr. Sowers, Lieutenant Dan, for chairing the session. Yeah, I actually have volunteered to chair, like when you do the submission of your paper or whatever, but I'm glad I wasn't selected. Because it's this awkward, like, I want to watch, but I don't want to look weird sitting up here at the desk. Yeah. So it's this one. Oh, okay. So active duty military. This is my views, not any view of the government. So a little background about myself. I've been in the military 22 years. In 2017, I went to the U.S. Naval Hospital in Yokosuka, Japan, and the civilian there, he was transferring and it was going to gap position. So I became the laser systems safety officer. The Navy at the time was using this acronym LSSO because there's also landing signal officers. So we had to make the acronym even more complicated. MLSO is what you'd call yourself in a civilian institution, a certified medical laser safety officer. Then I went to where I'm at now, Naval Undersea Medical Institute. Actually, I teach, my assigned topic is radiation medical exam. So now that I'm right here, I'm gonna elbow check Lieutenant Dan here. No, it's fine. But I also teach medical safety to our health physicist students or radiation health officers. That's what I am. And it's a half day of non-ionizing radiation, like how to run a good laser program. And then Miss Geyer invited me to the part 2 panel, and she saw my resume and said, hey, we found his lasers on his resume. So we found a laser guy, and it just seems like I've been doing lasers ever since I went to Japan. So, and this is my last Health Physics Society meeting, hopefully as a military member. So I wanted to get some travel dollars to come as an active duty military member. So here I am presenting following this great presentation. He warned me like, oh, you're after me. I hope everything's going to be okay. So lasers have a plethora of regulations, right? So the Center for Devices and Radiological Health is part of the Food and Drug Administration. They have 21 CFR 1040, which is our laser, like our laser guidance federal regulations. And then the ANSI standards, ANSI Z136.1 is the umbrella standard. And then what we're concerned with in the military treatment facilities for Defense Health Agency is Z136.3, which is lasers in healthcare. And then there's DoD regulations for running laser protection programs, whether it's medical or not. And then we have DHA Administrative Instruction 108. I did get advice from Lieutenant Commander Allen, and I think Dr. Smith was his name. He's the one in charge of lasers throughout DHA that we're coming out with a new DHA instruction. I've seen the draft, but I didn't want to speak to it, and since it wasn't approved. Not a lot of changes, but they did declare the laser safety officer to be the non-ionizing radiation safety officer. But so laser safety officer, my focus here, as you can see on the screen, you see a standard list of like job duties for a laser safety officer. I think since this is the Health Physics Society, we're all scientists in here. And if we were to approach a laser safety program or any kind of safety program, we're going to be great at Excel spreadsheets. We're going to be great at looking at PPE. We're going to be great at walking around with a clipboard and doing an audit. So I wanted to make something that applied to all services, the DHAs, all of us. And I wanted to talk about something that was difficult for me starting a laser protection program, and where I saw weaknesses and where I continue to see weaknesses talking to other people that are dealing with lasers in a medical setting. So I'm going to talk about, I know SOPs might seem kind of mundane, but I have a couple things I talk about: credentialing, medical surveillance, and accident response. Okay. And ultimately, these things, all of these things on the screen help us support a hospital's effort to become a Joint Commission accredited and provide superior medical care. So first, SOPs, Z136 calls them PMPs, policies and procedures, but standard operating procedures, SOPs, right? So it's recommended in the standards, they're not requirements. Standards are like the highest, best program you can possibly run. But in Z136.3, you should have a standard operating procedure for every department. And you, as a laser safety officer, should be looking at those standard operating procedures to make sure that they incorporate federal DoD agency regulations. Myself, when I was in Yokosuka, I designed a a new laser instruction for the command level to make sure it implemented the newest plethora of the things that are going to go around that word there. So command instructions as well. ANSI standards, just talked about that. So there's ANSI Z136.3. You should have a copy in your office if you're a laser safety officer, and also the Z136.1. Technical manuals is a constantly overlooked item that most departments have never seen. They don't know how to get a hold of it. If you don't have one in your department, in your clinic, like if ophthalmology is missing their technical manuals, it's probably with biomed. So you can get a hold of that and make sure that the SOPs incorporate how to turn on the machine, what to do if there's maybe there's a constant error code, and it's maybe nothing's wrong with the machine and you've cleared it with the manufacturer, but documenting historical items that you don't want lost to corporate knowledge. We transfer all the time. You don't want that information lost. It's good to put in the SOP. And then my disclaimer that I had at the front, this is basically like the one reason I think I have the disclaimer, because I put a commercial book in the presentation here. Industry and specialty practice, incorporating that information into SOPs is very important. ANSI Z136.3 has an appendix. I think it's Delta D, and it breaks down each specialty: ophthalmology, urology, dermatology, and it tells you how and what kind of lasers and how they're implemented. But it's only like 2 pages long for each specialty, if that. And so what this book does is, if you're a physicist or scientist and you're coming into a clinic and you have no idea about dermatology or what they do in that clinic, this book has 20 pages on each specialty, and it covers veterinary medicine, and it also has some of the physics. So if you decide you want to take like the certified medical laser safety officer exam, for example, this would be really good reading material to get you prepared. What you don't want to happen is what happened to a friend of mine. If you're not familiar, in urology, they do endoscopic exams up the urethra to ablate kidney stones. And so it's allowed per Z136.3. You don't have to wear laser safety eyewear because the endoscope is in the kidney or bladder. And so this friend of mine, our coworker, I was relieving him, LSO, and he goes like 10 minutes discussion about how the laser safety eyewear with the urology laser needs to be replaced and they should be wearing their laser eyewear. And after about 10 minutes, they just finally interrupted and said, we only do the endoscopic, kidney stone ablation. And he's like, oh, well, I look like a dummy. I should, so understanding kind of what the department does is very important. And then clinical procedures. So we have Genesis now, I guess. The composite healthcare system is what I was used to when I was at the hospital, and that's what you order. That's how you order your procedures. And so what procedures are done at the hospital, and are they covered in the SOPs? Because that book I just listed has maybe 200 procedures. I don't know. But if you only do 2 procedures in your hospital, then that's what you want to have. That's what you want to talk about in your SOPs. So with clinical procedures, that's what I ended with there on the last slide. Next, let's talk about credentialing. So credentialing happens when you have a new clinician come to the hospital. Anytime he or she goes somewhere new, or they're attached to a military treatment facility as a guest for an extended period of time, they're going to get credentialed by the credentialing office. And that's where they review the license and certification training and, the list of everything to make sure that you don't have a doctor who said they went to Princeton cutting open a patient. No, they didn't go to Princeton. They didn't go to school at all, but that you're letting them cut open a patient. I'm not going to sit up here and say that as a LSO or scientist, you need to go through this list. This is from the DHA's credentialing and privileging instruction. I'm not going to say we need to go through this entire list. That's not what I'm trying to say, but we need to be familiar with the items that go into credentialing. And what I did as a recommendation to you or anyone in this room that needs to do a laser safety program is we should have a process in place and codify it in a command instruction to ensure that there's a safe crossover between credentialing and laser safety. And so this form is what I did in Yokosuka, and it brings together all of the people that contribute to a good Joint Commission accreditation and superior medical care. So you've got the first one is clinical laser training. And it lists the approved procedures and it's signed off by the credentialing officer. And then laser safety training would be me as a laser safety officer. That's what I would sign off. And then medical surveillance, I'll cover next. And then everyone at my hospital knew that until I, as the laser safety officer and the supervisor of that clinician, until we sign off this form and I have it in my laser safety program binder, they are not to practice medicine using lasers at my facility. And if you can read, these names are all Austin Powers names, because I like to do my training revolving around movie themes. So I basically have a bunch of pictures of sharks with laser beams in my training. If you'd like to see that, I can send it to you separately. And privileging is basically if you have credentialing, that's if you have a circular process of ongoing review of a clinician or a provider's ability to practice medicine. Credentialing is at 12 o'clock. And then they go through the ongoing, like forever process of always being peer reviewed and just looked at, training for basic life support, BLS. And all that information goes in the provider activity file. And this is also from the DHA privileging instruction. So, yeah, I thought it was like 5 minutes. This is 8 minutes. So anyway, as an LSO, I made sure I had access to the provider activity file. The Navy, we used to call it the clinical activity file, but now that DHA took over, it's a PAF. And you can make sure that they're continually being reviewed in their practice of those laser procedures. Next is medical exams. So as I said in the introduction, the Code of Federal Regulations doesn't actually say anything about what medical exams are required. It actually just covers kind of like the equipment piece of lasers and how to check them for alignment, things of that nature. Z136.1 Appendix F covers medical examinations, and there is basically it says there's no chronic risk for use of lasers. So they don't need routine examinations, and what DHA requires is a baseline and a termination exam if you're at risk. And so the DHA Administrative Instruction 108 talks about if you're a laser worker or you're an incidental laser worker, you need to have a laser eye exam, and it directs you to the DoD manual, that number. And that's basically, I forgot to put the title of it in there, but that's the Occupational Medical Exam Manual for the DoD. And the most recent revision doesn't actually differentiate the difference between a laser worker and an incidental laser worker. And so I'd spent about a month digging that down, and I found this is the newest version, I think 2018, but if you go back in time to the 2007 version of the same manual, it has a very clear definition of the two. So laser worker is someone who routinely works in a laser environment. And it specifically says, like, if you work near medical lasers found in operating rooms. And so this is entire DoD. So there's a plethora of examples. Like if you work on a laser beam on a shark or something, like it'll talk about that too. So then it says if you have a moderate to high risk potential for laser energy. Okay, great. An incidental laser worker are those that make it possible, but it's really unlikely that you're going to have laser energy that could damage the eye, and it's considered low risk. And so what we run into here, and what I experienced was, I'm a laser safety officer. I'm also a radiation safety officer. I didn't have a permit in Yokosuka, but I covered the diagnostic imaging machines and whatnot. So if I have too many workers and it becomes an administrative burden, then I teeter one way. But if I don't have enough, then I might have a missed opportunity for an acute accident where someone gets an eye exposure if they were working closely with the laser. So it's a decision that you would have to make and put it in writing in a command instruction or an SOP that says, here are the people that I define to be laser workers. Here are the people that are assisting with laser procedures, maybe nurses and other in the Navy. We have corpsmen, but those people that come in, they're going to have to wear laser eyewear if they're in the area. I mean, that's not in question, but it's whether they need to be in the occupational surveillance program or not that comes to question. So that's your decision as an LSO. And then, so if you do have an accident, we go into the next topic, and I'll speed this up here so I can take a question or two, but there's the DHA and the DoD instructions. Those are the same two instructions from before, but there's also 21 CFR 803, medical device reports, MDRs. So if you have basically, if you have someone that gets an eye injury, you need to evacuate them immediately. And so you need to call the Tri-Service Laser Hotline. I wanted to try and call it before I came, but I didn't want to cause any problems just to make sure. But I've seen it on multiple websites and I've verified the number, because what I'm going to tell you after I also talk about the laser accident and incident registry, this number right here, if you're ever going to do laser safety work, take the time now and put it in your phone. Put it in your phone right now. I don't see anyone pulling out their phone. No one's going to take my advice. Okay. You don't, it just will make you look so much better if you do have some kind of accident. You're like, I've got their number. Let me pull out my phone. Here you go. And then the last thing here is the 21 CFR 803. If you have a suspected injury or a device use or malfunction, go to this website. I'll definitely go through your chain of command, talk to the DHA Radiation Safety Committee. But this CFR requires you to report those two types of things: injury or device use or malfunction. So go to this website. And when you go to the website, you can do an advanced or simple search. And if you have a certain make model of laser, you can do either search option, but you can search it. And then, so in this example, there's a luminous power laser that I found because it's one that I had. And you can get the information on any past events or any kind of malfunctions on that specific piece of equipment. And you can find that information, and there's pictures. So this one had a damaged lens because of how the cooling was affected by internal electronics, something of that nature. And it's just interesting. You know, you can go look at other people that have reported these things, problems with that same piece of equipment. So anyway, in summary, being a good LSO is more than just maintaining Excel spreadsheets. We have the ability to support hospital accreditation and superior medical care if we just take the time to understand the medical practice, which sometimes takes a little bit of effort because it's out of our comfort zone. And again, the new DHA administrative instruction is coming, so please be on the lookout for that. If you have questions, there's 2 minutes and 47 seconds.
I didn't get one. I think Jeanette's got a question.
Sorry, I'm short. I was just wondering, now that the ANSI has changed their recommendations for the medical surveillance, does the DoD require still the baseline eye examination?
I only recently saw that the Z136.1 had changed within the last month, and I'll take the fall for them, but my command got their government purchase card suspended, and I wasn't able to order the new Z136.1 to change the training or add to the training. Since the DHA instruction is not approved yet, there's many DHA people in the room. I'm sure they'll take that statement back and make sure that before it's published that it's incorporated.
Well, it was actually the 2014 revision to
It's
been out a while.
This reflects the 2014.
So they found that it wasn't useful to conduct that baseline eye examination.
Well, my understanding was it says that the routine examinations were not useful, but if you're at risk of severe injury, then they recommended they said it's okay to do a baseline exam. They didn't say
right, not routine baseline exam.
They didn't say don't do it. They just said it's not necessary, and it should be up to the individual command or organization to determine if they want to do a baseline.
And because they were sending a lot of people to the ophthalmologist, and the ophthalmologist didn't really know what they were.
So that graph ad is actually like both command safety officer happiness, but ophthalmologist happiness, because we only had one, and she was overloaded, but because I had too many workers.
Thank you. And since I'm up here, one response to the gentleman that spoke about Dan Sauer's presentation, I just wanted to point out that a lot of the people that work at the shipyards are civilians, and we have a much different culture when it comes to qualifying and disqualifying, telling us what we have to do.